The hearing will come to order. Let me first thank my distinguished ranking member, Chuck Grassley, for being here. We've worked together. We had a brief sidebar before I turned on the microphone, and he pointed out that this has always been a very bipartisan committee, and I pointed out that he and I had always worked well together on top of it, so there's a good personal overlay here. So I hope to be able to continue that, and I thank him for being here. I'll give a brief opening statement, and then I'll turn to Senator Grassley for his opening statement, and then we will turn to our first panel, and I will yield my questioning time, since I'm going to be here through the whole hearing, first to the ranking member, Senator Grassley, for whatever questions he may have, and then on to the senior person on our side, and we're doing it by gavel, so that would be Senator Hassan. So she'll be our leadoff questioner when we're done, and then we'll proceed forward from there to the panel. I will announce to all of you that by virtue of the way the Senate operates, your testimony is taken as sworn, and I'll spare you the Photoshop moment of putting your hands up, but it doesn't change the requirement that your testimony be under oath. So welcome everyone to our first Drug Caucus hearing. Drug traffickers prey on American demand for illegal drugs, and the consequences for our people and for our communities and even our democracy are deadly. My goal in my time as chairman of this Drug Caucus is to shine a light on the dark economies drug traffickers harness to hide their ill-gotten gains. In coming hearings, we'll examine how drug trafficking networks exploit our rule of law and financial systems to sustain their criminal enterprises. We'll lay out the foundation for this work with today's hearing, which focuses on the federal response to the drug overdose epidemic and the drug threats that have emerged or changed as a result of the COVID pandemic. After a modest drop in 2018, overdose deaths surged to over 93,000 last year, a new record. 400 of them were my fellow Rhode Islanders. While synthetic opioids like illegally manufactured fentanyl are the primary driver, these deaths often involved multiple substances used together. This dramatic increase, accelerated by COVID, underscores the need to revise and improve our drug policies. An effective strategy should reduce U.S. demand for illicit drugs by expanding prevention, treatment, and recovery infrastructure, and build and strengthen our domestic and international partnerships to reduce supply, and attack the financial networks that drug traffickers utilize for their ill-gotten gains. We know prevention and treatment save lives and money. The National Institute on Drug Abuse estimates that illicit drug use costs the United States over $600 billion per year. Every dollar invested in evidence-based prevention can save up to $20, and every dollar invested in treatment can save up to $7. So we have to continue to invest in effective prevention, treatment, and recovery programs. In recent years, we've enacted bipartisan legislation to do this, including my bill, CARA, and provisions of CARA 2.0. These laws have infused billions of dollars into our substance abuse prevention, treatment, recovery, and enforcement infrastructures. But more remains to be done, which is why I introduced CARA 3.0, a bipartisan bill to invest $785 million into expanding access to treatment and building the addiction medicine workforce. It also includes measures to ensure equitable and culturally competent care. The COVID pandemic forced us to expand access to treatment through new strategies and technology, and I've introduced legislation to permanently allow prescribers to use audio-video telehealth evaluation to prescribe Schedule 3 and 4 medications to treat substance use disorders, and to allow for Medicare reimbursement for those services. The pandemic forced this innovation, and now we know it can work. We should seize the moment, which is why I'm pleased to see that ONDCP's statement of policy priorities largely aligns with the provisions in these bills. As the success of the CARA legislation shows, efforts to reduce demand for drugs need to emphasize public health. Still, we must think clearly about the vast supply of drugs flooding our communities from abroad and what it will take to stem that flow. With a skilled chemist and the right precursor chemicals, drug traffickers can produce an infinite array of new synthetic drugs to wreak havoc in our communities. Traffickers in Central and South America can easily obtain those precursor chemicals, so an effective federal strategy must strengthen international partnerships to attack the supply chain. Finally, given that drug traffickers are motivated by money, An effective federal strategy should explicitly prioritize efforts to understand and aggressively attack the financial networks that traffickers exploit. As part of this effort, ONDCP should convene an interagency working group to determine whether the disruptions in trade-based money laundering schemes, dark web activity, and bulk cash smuggling that occurred during the COVID-19 pandemic can be maintained. The rapid escalation of drug overdose deaths during the pandemic means we must re-examine and strengthen our existing drug policies. At the state level, I'm particularly proud that Rhode Island has done so much to refine its policies under the leadership of Wamazetta Jones. We must mirror that success on the federal level. I look forward to hearing what witnesses think of the federal response to the drug overdose epidemic, how the pandemic has deepened the crisis, and what we can do to save lives. I recognize Ranking Member Grassley for his opening statement.
Thank you, Mr. Chairman. You correctly stated our working relationship, and particularly on this caucus over a long period of time that I've served on it, whether Republicans have been in the majority or Democrats in the majority, there has been a strong bipartisanship, and there ought to be, and it's easy here. So I look forward to continuing our relationship now that you have become chairman. Also, I welcome all of our witnesses today, as I had a chance to say hello to you in the anteroom. 93,000, that's a number of how many people died from drug overdoses last year. This is the sharpest annual increase in 30 years. The New York Times wrote that 2020's overdose death numbers eclipsed the peak yearly deaths from car crashes, gun violence, and AIDS epidemic altogether. That ought to be an astonishing figure for all of us to consider. No region was spared last year. Every corner of the United States suffered an increased death toll. The main culprits, COVID-19 and deadly fentanyl analogs. So today's hearing is timely because it's urgent that we evaluate our federal approach on the drug crisis. COVID-19 played a significant role in the increased drug overdose rates. The pandemic brought about a social isolation trauma, job losses, made necessary tools like access to treatment even more difficult. Data shows us that overdoses took off in March 2020 when the pandemic-driven shutdowns and physical distancing measures all began. We must learn how to navigate drug policy in a post-COVID world. What lessons did we learn? How can we improve? These are questions that I want answered. Also, fentanyl analogs are driving up the death toll. According to Customs and Border Patrol, the amount of fentanyl and analogs seized so far this fiscal year nearly doubles what was seized in all of 2020. This statistic alone should be enough to compel serious long-term actions on controlling deadly fentanyl-related substances. Drug dealers often mix fentanyl with other drugs like meth, cocaine, and marijuana. Traffickers prey on those suffering with addiction by adding deadly analogs to other drugs. Sometimes users know what they're consuming, that they're consuming a fentanyl substance, but sometimes they don't know that. In any event, the data speaks for itself. Polydrug abuse, mainly due to fentanyl substances, is a driver of overdose deaths. So at a time of record drug abuse and deaths, where should our priorities be? I recently outlined in a letter to the Office of National Drug Control Policy, which I think must be prioritized in federal approach to drug policy. Among others, I highlighted the need to build a plan to deal with historic levels of methamphetamine supply and use, that we need to address polysubstance trafficking, and we must proactively address fentanyl analogs. The authority to schedule fentanyl substances expires in October. The administration must support efforts to proactively and permanently schedule fentanyl analogs. To do anything less will surely enable the spread of these deadly drugs. I'm grateful that Acting Director LaBelle invited me to weigh in on the National Drug Control Strategy, and I'm pleased to have her testimony today. We must work together in a whole of government approach to assess gaps in policy so we can tackle the crisis. Simply put, it's a matter of life and death. 93,000 Iowans or Americans lost their lives last year because of the rampant scourge of drugs in our country. I hope we all agree that this must end. Thank you again for today's witnesses for being here. I look forward to hearing about how we can work together to strengthen our approach and combat this problem. I'm done. Thank you.
Would you like to go straight to questions, or shall I let Maggie go first?
Don't you want them to testify?
Yeah, but I'm going to be here, so I was going to yield my questions to you or to
Yeah,
Maggie.
I'll be first.
You're ready to go ahead with your questions?
Yeah, but
Oh, sorry.
I'm sorry. I thought that's what I was trying to tell you.
Yeah, my apologies. I was going straight to questions. I see all these witnesses here I want to ask questions of. So let me just do quick intros, and they can each make their statements. Ms. LaBelle is Deputy Director and Acting Director for the Office of National Drug Control Policy. She was a distinguished scholar and program director of the Addiction and Public Policy Initiative at Georgetown University Law Center's O'Neill Institute for National and Global Health Law, and founded and directed the Master of Science in Addiction Policy and Practice program at Georgetown University. She has also served as the ONDCP Chief of Staff, so she certainly knows her way around the organization, and I welcome you today, Ms. LaBelle. Tom Kader is the Acting Deputy Assistant Secretary for Mental Health and Substance Abuse at SAMHSA, and is the first person in recovery to lead that agency. In his role as SAMHSA's Region 1 Administrator, Mr. Kader led the prioritization of prevention, treatment, and recovery services through COVID-19, while Chief of Staff to the Assistant Secretary for Mental Health and Substance Abuse and Senior Advisor to the Administrator. You guys go for really long titles in this line of work. Mr. Kader led the team that produced Facing Addiction in America, the Surgeon General's report on alcohol, drugs, and health. As a senior political appointee, he has represented SAMHSA at the White House and other HH offices and operating divisions, and has been involved in leadership positions in the state of Rhode Island, as well as the National Field Director of Faces and Voices of Recovery. Dr. Volkow is Director of the National Institute on Drug Abuse at the National Institutes of Health. Her work has been instrumental in demonstrating that drug addiction is a disease of the human brain. As a research psychiatrist and scientist, Dr. Volkow pioneered the use of brain imaging to investigate the toxic and addictive properties of abusable drugs. Most of her professional career was spent at the Department of Energy's Brookhaven National Lab in Upton, New York, where she served as Director of Nuclear Medicine, Chairman of the Medical Department, and Associate Director for Life Sciences. She was also Professor in the Department of Psychiatry and Associate Dean of the Medical School at SUNY Stony Brook in New York. And she has also co-edited the Neuroscience for the 21st Century Encyclopedia. So this is a stunning array of witnesses, and let me ask Ms. LaBelle to proceed with her testimony.
Chairman Whitehouse, Co-Chairman Grassley, and members of the caucus, thank you for inviting me to join you today to discuss the Office of National Drug Control Policy's role in the federal response to the drug overdose epidemic. I'm honored to testify as the acting director of the agency where I served for 8 years in the Obama administration. ONDCP coordinates drug policy through the development and oversight of the National Drug Control Strategy and the National Drug Control Budget. As acting director, I act on critical current and emerging drug issues affecting our nation by facilitating close coordination of federal agency partners on supply reduction and public health efforts, and by overseeing our budget authorities to ensure that adequate resources support the nation's drug policy priorities. ONDCP's central coordinating role in drug policy has never been more important. As you said, the CDC estimates more than 93,000 people died of an overdose in 2020. These overdoses involve illicitly manufactured fentanyl, fentanyl-related substances, psychostimulants such as methamphetamine and cocaine, all increased by double digits. The COVID-19 pandemic exacerbated the overdose epidemic and overdose rates were beginning to rise even before the pandemic began. The drug environment we face today differs significantly from even 5 years ago and requires an urgent response. Since President Biden took office, he's made it clear addressing addiction and the overdose epidemic is a significant priority. On the public safety side, he's focused on reducing the supply of drugs entering our country by strengthening interdiction, domestic law enforcement, and international partnerships. For example, we're working across the interagency to develop a solution on scheduling fentanyl-related substances. We're grateful that Congress extended the temporary scheduling earlier this year, as it's given us an opportunity to develop a consensus approach to the issue. On the public health side, the President is focused on expanding access to the continuum of care for people with substance use disorder. We've already taken several actions. The administration removed the X waiver for prescribing buprenorphine to 30 or fewer patients, making it easier for physicians and other medical practitioners to treat patients with opioid use disorder with the standard of care. We've allowed federal funds to be used for fentanyl test strips, and we've ended a decade-long moratorium on methadone bans so treatment can be brought to underserved communities. In addition to the actions outlined above, the Biden-Harris administration has dedicated historic funding to address addiction and overdoses. The American Rescue Plan, which Congress passed in March, invested nearly $4 billion in vital mental health and substance use disorder services. This funding also included $30 million for harm reduction services, an historic amount. In May, President Biden released his first budget request, which calls for $41 billion to fund drug policy programs. This includes both public health and public safety efforts, including an unprecedented focus on prevention, treatment, harm reduction, and recovery support services, while also supporting key drug supply efforts. Last week, ONDCP announced new high-intensity drug trafficking areas discretionary funding, which includes funding to bolster public health and public safety collaborations. Earlier in the year, we also announced that the HIDA overdose response strategy, which brings together local public health and public safety leaders to address overdoses, will be extended to all 50 states. And in June, our office announced new grant funding provided by Congress under Chairman Whitehouse's leadership through the Comprehensive Addiction and Recovery Act. This enhances the work of community coalitions to prevent youth drug use. And more grants will be released through our Drug-Free Communities program throughout the summer and fall. All of these actions fall under the Biden-Harris administration's drug policy priorities for the first year, the guiding principles as we formulate the National Drug Control Strategy, which is due to Congress next February. The priorities also represent a focused approach to reducing overdoses, creating more opportunities to engage people with substance use disorder, targeting and disrupting drug trafficking networks at home and abroad, including through anti-money laundering efforts, and ultimately saving lives. The priorities provide guideposts to ensure that the federal government promotes evidence-based public health and public safety interventions, which include advancing racial equity in drug policy and embracing a full continuum of interventions. These actions and this funding are just the start of the administration's historic commitment to ensuring the federal government promotes evidence-based public health and public safety actions. I thank members of this caucus for their work to advance effective drug policy, and I look forward to today's discussion and continuing our important work together.
Thank you very much, Director LaBelle. Mr. Kader.
Good afternoon, and thank you, Chairman Whitehouse and Co-Chair Grassley, for inviting me to testify today, as well as to the other members of the committee joining us this afternoon. My name is Tom Kader, and I'm currently serving as the Acting Assistant Secretary for Mental Health and Substance Use at SAMHSA. I'd like to start today by sharing a short story with you. This story is about a man who came from a loving family and had many friends. He was involved in his community, enjoyed politics and policy, and was elected to the state Senate at 25 years old. By 30, he had risen in his career to become the executive director of a large nonprofit agency. On the outside, everything about this man's life looked normal. Some would even say perfect. However, on the inside, he was tortured. So he turned, first to alcohol and then to other drugs to cope with the stresses he was experiencing. Underestimating the power of these substances and not understanding the neurological consequences of taking them, He quickly became addicted, and his life began to unravel. He started to lose the things that were most important to him. When his family and friends tried to help, he resisted their help, and he pushed them away. This caused him to lose them. He lost his job, and he lost his position in the Senate. His health deteriorated. He lost his apartment and became homeless. He lost his spirit. In the end, he lost everything, even his desire to live. This man's life, which at one time was so full of hope, became hopeless. I know this story well because it's my story. But I was able to get the help that I needed. And today, I'm a person in long-term recovery, which for me means I haven't used alcohol or drugs since May 15th of 2003. During these 18 years in recovery, my life has vastly improved. Being in recovery has enabled me to not just create a better life for myself, but also to create a better life for my family and ultimately my entire community. With help, people can and do recover from substance use disorders. I'm here today not only representing SAMHSA, but also the 22 million Americans who have resolved their issues with substances. Unfortunately, too many people do not have stories as hopeful as mine. And the COVID-19 pandemic has exacerbated the already crisis-level drug overdose epidemic, presenting new challenges for SAMHSA. Last week, the CDC, as you have already mentioned, released devastating data revealing more than 93,000 people died from drug overdoses in 2020, a nearly 30% increase from the previous year. Even one life lost is too many, and SAMHSA is committed to doing all we can to turn that data around. To do so, SAMHSA is focused on each aspect of the care continuum: prevention, intervention, treatment, of course, and recovery support. For example, this past April, SAMHSA expanded treatment services nationwide when HHS Secretary Becerra issued buprenorphine practice guidelines, removing the barrier for providers to treat more patients with buprenorphine. We are proud to report that we have already seen this change increase the number of providers prescribing medication-assisted treatment. More Americans are now able to access evidence-based treatment, allowing them to move into recovery from an opioid use disorder. SAMHSA has also focused on harm reduction as the first prevention intervention for people who use drugs. Harm reduction programs promote the widespread dissemination and implementation of evidence-based strategies, such as syringe service programs aimed at reducing negative consequences associated with drug use. In particular, the distribution of naloxone and ensuring individuals have access to life-saving medication is a large focus of SAMHSA's state opioid response grants. Grantees report using naloxone to reverse nearly 200,000 overdoses. We have lost so much over the COVID-19 pandemic, but tragedy has also forced innovation. The use of telehealth is increasing access to screening, assessment, treatment, crisis support, medication management, and recovery support across diverse behavioral health and primary care settings. SAMHSA looks forward to working with Congress to ensuring access to care is not lost as we move beyond the pandemic. Thank you for the opportunity to appear before you today and for your attention to this important topic. I welcome any questions that the caucus members might have.
Thank you. For senators on the panel, Tom Kadare used to be Senator Tom Kadare in the Rhode Island Senate. And then the trajectory that he described took place and crash dive to rock bottom, and now here he is in front of us in the United States Senate on this panel. So it's a powerful story of what recovery can mean.
Humbling experience, Senator. Thank you.
Yes. Delighted not to have to experience it, but delighted that you came through so well. Dr. Valco, please proceed with your testimony. Welcome to you.
It's not working. Yes. Good afternoon, everyone. Chairman Whitehouse, Co-Chairman Grassley, members of the caucus. Thanks very much for giving me the opportunity to speak to you. I represent the component of agencies that does science, And my task here is to try to illuminate some of the solutions that science can bring to the opioid crisis. You just heard the overdose death has been at its highest in the United States, so from what we've ever been recorded in 2020. And it seems that illicit fentanyls and analogs are presumably mostly responsible for those deaths, though cocaine and methamphetamine and the combination of these drugs is increasingly of greater and greater concern. We have medications for treating opioid use disorders, but certainly there are more options that are sorely needed. With support from the Congress and the funds for the HEAL initiative, NIDA research has led to FDA authorization of 16 investigational new drug applications for opioid addiction treatment, including vaccines to prevent opioids from entering the brain. NIDA is also prioritizing development of treatments for stimulant use disorders for which there are currently no FDA-approved medications. We are encouraged by recent research findings that a combination of 2 FDA-approved drugs for other indications, bupropion and naltrexone, reduce methamphetamine craving and use in patients with moderate to severe disorders. And also by positive safety findings from antibodies that could help reverse methamphetamine overdoses. Just as important, it is critical to support implementation research to help expand access to treatments that work, for only a fraction of people who need them receive them. Stigma, inadequate reimbursement, poor treatment compliance, policy barriers that limit access to these medications all contribute to this deficit. New models of care have already started to make treatments more accessible and sustainable. For example, NIDA's clinical trial network has done studies showing that opioid use disorders can be successfully treated in emergency departments, as well as other healthcare settings. NIDA's Justice Community Opioid Innovation Network is testing ways to expand addiction treatment for people in justice settings. And through the Healing Community Study, we're investigating how the delivery of a battery of evidence-based prevention and treatment approaches in partnership with multiple agencies can be used to reduce opioid overdoses and deaths by 40% in some of the hardest hit communities in our country. NIDA has also helped biotech startups develop innovative technologies that translate addiction science into healthcare and some consumer products. One such example is the development of the first ever FDA-approved digital medicine, which puts psychosocial treatment for substance use disorders right into the hands of anyone with a smartphone. Other innovative approaches include digital applications for overdose detection and automatic activation of emergency support, applications to monitor patient medication compliance, and applications to connect individuals to treatment and support groups. Research has also shown that people who use drugs are more vulnerable to getting infected with COVID, and if they get infected, are at greater risk for death. This is especially true for Black people, a population that has already been disproportionately affected by the pandemic. NIDA is supporting more than 100 studies at the intersection of COVID-19 and substance use, including research to examine how healthcare policy changes implemented during the pandemic, such as take-home methadone and increased use of telehealth, affect the outcomes. We are also capitalizing on 2 large ongoing longitudinal studies, one in adolescents, the Adolescent Brain Cognitive Development Studies, and one in infants, the Healthy Brain and Child Development Study, to examine the impact of COVID on brain and behavioral development. These studies will also inform our understanding of what is normal health child development from prenatal period through young adulthood, and how it is affected by biologicals and environmental factors such as exposure to drugs during pregnancy, during development, being infected with COVID, and pandemic-related stressors. Ultimately, the information will be crucial for tailoring prevention interventions that are necessary to address the crisis. And finally, it is the close collaboration with all of us that is going to enable us to address the epidemic. I thank you very much for inviting me to be part of this.
Thank you very much, Dr. Valco. The order of questioning will be Senator Grassley, Senator Hassan, Senator Cornyn, Senator Blumenthal, Senator Whitehouse, and then we'll turn to the second panel.
I thank you, Mr. Chairman. To Director LaBelle, ONDC released an outline this year about policy goals. I feel a number of important issues were noticeably absent, so at your invitation, I sent a letter outlining what I thought ought to have priority. This includes permanently scheduling fentanyl-related substances, dealing with an increased methamphetamine threat, and lastly, addressing polydrug trafficking. Permanently controlling fentanyl-related substances is a priority for me. Currently, they're temporarily placed in Schedule 1. That authority ends October. ONDCP is leading the effort to draft legislation to control these drugs. My staff has been in contact with yours on steps forward, but very little information has been shared with Congress, and I'm worried that your proposed solution won't permanently schedule these drugs. Will your legislative proposal permanently schedule fentanyl-related substances?
Thank you, Senator, for that question, and also thank you very much for your letter, which consisted of many of the items that we are going to cover in our strategy, which will be released next year. As to fentanyl scheduling, as you mentioned, we've talked to your staff about this. My staff is working diligently with DOJ, the Drug Enforcement Administration, and HHS to make sure that what we send to the Hill meets the needs of the Hill, but also that it checks all the boxes. So we're doing diligent work right now. I can't tell you all the details of it because I can't get ahead of the process that we're going through, but I can assure you that we'll meet our deadline and we will work diligently on this matter to make sure what we send to the Hill is a good product.
I just don't have a handle on why Congress is so reluctant to be very strong on this issue. And I say that considering how very dangerous fentanyl is. I wish somebody would explain to me that. I'm not asking you to. So last month you testified before the Senate Judiciary Committee that you were working to present Congress with a legislative proposal sometime this fall. Is that still the case, and do you have any updates on that?
Yes, sir. We will have legislation to the Hill prior to the expiration of the Fentanyl Scheduling Act. And so the update is that I actually think we're making good progress, and we're going to have something on time to the Hill.
In addition to fentanyl, the National Drug Control Strategy must address methamphetamine. That's my second point. According to the CDC, more than almost 17,000 people overdosed from meth 2019, which is a 30% increase from 2018. This rate keeps going up. Senator Feinstein and I introduced a bill that prioritizes stopping this crisis by declaring methamphetamine an emergency drug threat. This bill would also require ONDCP to develop and implement a national plan on meth addiction. So, Director LaBelle, if you agree that methamphetamine is an emerging threat, how does ONDCP plan to address the surge in supply and abuse of meth?
Thank you, Senator. As you said, we're seeing methamphetamine crop up in places that had never seen it before. Certainly in the Northeast, we're seeing more in New Hampshire. And methamphetamine has been a direct threat in the state of Iowa for many years. So what we're doing, we are working on a plan. It will be rolled out. We want to make sure that it includes the public health and the public safety efforts that are important to this. As you mentioned, the meth that we're seeing right now is not what we used to see. It's coming from Mexico, mostly liquid meth. And so there are law enforcement efforts that need to be undertaken, and that's why our high-intensity drug trafficking areas program, we asked for increased funding for them in the next year so that they can continue to disrupt drug trafficking networks and go after illicit methamphetamine.
Polydrug use and trafficking also needs to be central to the strategy. Nowadays, an overdose isn't due to only one drug. As you know, users are often addicted to multiple drugs, and traffickers adapt and sell any drug that makes a dollar. This problem is exacerbated by the influx of constant threat of amphetamine analogs. So to you again, how is ONDCP addressing polysubstance trafficking and its use? And are you leveraging programs like the drug-free communities and high-intensity drug trafficking areas to deal with the problem? And this will have to be my last question.
Sure. Thank you, Senator. So the Drug Free Communities Program and the HIDA program are two of our programs that ONDCP oversees. We not only kept those programs in the Office of National Drug Control Policy, which is where they belong, but they also, we requested an increase in those programs. We strongly support both of them. They show the two sides of this issue, which is drug prevention efforts as well as going after supply reduction efforts. The HIDA program, what's so great about it is that it's a force multiplier. It uses the strength of federal dollars and is matched with state and local efforts to go after drug trafficking networks.
Thank you. Thank you, Mr. Chairman.
Thank you, Senator Grassley. Senator Hassan.
Well, thank you, Chairman Whitehouse and Co-Chairman Grassley, for holding this hearing, and to our witnesses, thank you for your service and your work. It's really critically important, and as you know, my state of New Hampshire has been hit hard, particularly by fentanyl and now meth, for years now. And so I really appreciate your work, but boy, do we have a lot of work still to do. Director LaBelle, as Co-Chairman Grassley mentioned, we've seen a disturbing increase in the supply of fentanyl analogs. And we have heard, my colleagues and I, from law enforcement that tracking and regulating various analogs can feel like just an unending game of whack-a-mole. Director LaBelle, you and the co-chairman have now mentioned that the current temporary prohibition on fentanyl analogs will expire on October 22nd. The co-chair, along with Senator Feinstein, Senator Ernst, and I recently introduced the bipartisan Stop Importation and Manufacturing of Synthetic Analogs Act to give the Justice Department the power to continue regulating these dangerous analog drugs. Now, you've mentioned that you will have a strategy, a legislative strategy, coming up to the Hill before the October 22nd date, but suppose there isn't action by that date. What steps can the administration take to help combat the trafficking of these extremely dangerous fentanyl analogs?
Thank you, Senator. So we intend to have legislation to the Hill well before it's due. That is something that we are working on diligently. My staff meets weekly across the interagency. So I will answer hypothetically if that doesn't occur.
Right.
You know, the Fentanyl Scheduling Act there were many pieces put into place prior to this year in the last Congress that allow us to go after the financial aspect of fentanyl. So there are many things that we're doing, including working with the global network of fentanyl trafficking. So working with China about precursor chemicals, working with the Mexican government and our Drug Enforcement Administration partners to make sure that fentanyl is not coming over the border, that they're disrupting labs that are happening in Mexico. So it is a complex issue that involves many more agencies than just ONDCP.
Okay, well, thank you, and I'd look forward to continuing to work with you on that and share our legislation or answer any questions you have about it as well. I have another question for you, Director. The COVID-19 pandemic changed traditional supply networks for many products, including deadly illicit drugs. During the pandemic, many purchasers started buying these drugs through dark web marketplaces. These networks anonymized transactions to help suppliers evade law enforcement. I was encouraged to see that the Department of Justice, through the Joint Criminal Opioid and Darknet Enforcement J-Code, disrupt a number of these dark web marketplaces last fall with Operation Disruptor. Director LaBelle, how can ONDCP work with other federal agencies, including DOJ, to help combat drug trafficking on the dark web?
Thank you, Senator. So certainly anti-money laundering efforts are significant, and we really appreciate Congress's passing the Anti-Money Laundering Act. Okay. That really was a game changer, and it also allows the Department of Treasury to go after illicit activities. and to make sure that they are one step ahead of drug traffickers who are changing their tactics on a regular basis. So what ONDCP does is a couple things. One is that because again, everything we do it requires coordination. This issue is very complex, and we need to bring DOJ as well as the Treasury Department in. So we have regular coordinating meetings to discuss tactics and strategies. And the second thing we do is on the National Drug Control budget is to make sure that FinCEN and the Department of Treasury get the resources that they need to enforce these laws.
Thank you. One more question to Dr. Volkov and Mr. Coder. Earlier this year, I reintroduced bipartisan legislation with Senator Murkowski to expand access to medication-assisted treatment for those struggling with opioid use disorder. Specifically, our legislation would eliminate completely the outdated waiver requirement that prevents many healthcare providers from prescribing medication-assisted treatment to their patients, the so-called X waiver that you've all mentioned. In April, the administration announced steps to remove some of the requirements that this waiver imposes, but there are additional steps that Congress must take to eliminate the remaining barriers. So, Mr. Coder, you've spoken in the past about the importance of medication-assisted treatment and barriers to access. How do we fully address these challenges and expand access to medication-assisted treatment? And I'll just add, what I'm looking for here is the waiver that's in place still says that doctors can only treat 30 patients, and also doesn't alleviate the training requirements for all practitioners. So how can we make progress here?
Well, thanks so much for your question, Senator. The spike we've seen, of course, in opioid-involved deaths during the COVID-19 pandemic requires us to do all we can to make treatment more accessible to patients. And Americans with chronic disease need and deserve readily available access to these life-saving medications. That's why in April, Secretary Becerra issued...
Right, and I'm running out of time, and I understand what he did. It isn't everything we need to do, and I think there are still issues of stigma here that are interfering with our ability to integrate substance use disorder treatment into primary care, and that's what I'm really looking for is not what you've already done. We all agree on what you've already done. What are we going to do next?
Well, HHS has taken this to the statutory limit that we can, but we're looking forward to working with Congress to find other ways to take this further.
Okay, and could I have Dr. Volkov just speak about this for a second, please?
Extremely important issue, and can you hear me?
Yes.
Yeah, and it is definitively it will expand access to clinicians that can prescribe buprenorphine. However, we have to be mindful that it is not the only roadblock, and one of the issues that has become interfering with expansion is reimbursement, and that we need to actually evaluate the extent to which this restricted reimbursement for treatment of opioid use disorder is acting as a barrier, and also access to buprenorphine. We have models of care which actually take advantage of pharmacies, of primary care physicians that have proven to be as effective as those on specialized treatment programs that are also much less costly. So expanding alternative ways of delivering the treatments is an incredible opportunity that we have.
Thank you very much, and thank you for your indulgence, Mr. Chair.
Of course, and now I turn to my partner in the Residential Substance Use Disorder Treatment Act and in our work on crisis intervention in law enforcement, Senator Cornyn.
Thank you, Mr. Chairman. Ms. LaBelle, you talked about the coordination that your office does with, I believe you said, the Department of Justice and others. But what I want to reflect on here, or ask you to reflect on here for a moment, is the current humanitarian crisis we're experiencing at the southern border. About 1 million encounters this year alone with migrants attempting to enter the United States, the vast majority of whom will not qualify for asylum or legal entry. The Border Patrol tells me that because of those tactics used by the smugglers, they're flooding the border with unaccompanied children, for example, and out of compassion, of course, and necessity, we would want the Border Patrol to take care of those children while they're in our custody. But they also tell me that is when the cartels take advantage of the 40% or so of Border Patrol off of the front lines and then move drugs across the border. So my question is ONDCP coordinating with the Department of Homeland Security and the Drug Enforcement Agency to react to the cartel's tactics along the southern border?
Thank you, Senator. So we certainly work very closely with Customs and Border Protection and DEA on the drug trafficking across the border. And it's not solely at the border. We also work with DEA and our other INLs, State Department, on drug trafficking that occurs in Mexico, as well as the global network. So China, and which is the source of other precursor chemicals, as well as India. So it's a complex web that at the end, when it comes across the border, Customs and Border Protection does seize the drugs. And then when it comes into the United States, our high-intensity drug trafficking areas program, there are many across the southwest border, they also disrupt drug trafficking. So we work very closely across the interagency to make sure that there's this web and this force multiplier so we can enforce the drug trafficking laws.
Well, clearly, we're losing that fight at the border in particular, which would be an ideal place to interdict drugs coming from anywhere around the world. But the fact is that the vast majority of them come from Mexico and south of Mexico, Central and South America. But last year alone, there were 8,500 pounds of fentanyl seized by Customs and Border Protection. It's a huge increase in volume over previous years. I wish the administration would look at the business models of the cartels, which include smuggling not only people, but also drugs at the same time. And it seems to me that, again, we are losing that battle. Ms. LaBelle, let me ask you about the bill that Senator Whitehouse and Mr. Cordier, I'd like to get your comments as well. We've introduced a bill called the Residential Substance Abuse Disorder Treatment Act of 2021. We've worked together on prison reform and other criminal justice reforms, but it occurs to both of us, I'll let Senator Whitehouse speak for himself, but I think it occurs to both of us that we need to have follow-on treatment for people who are released from prison. 85% of whom will be somehow associated, either they committed a drug-related crime or they are addicted or using drugs. And so if they go back to the same neighborhood, the same associates, and the same environment that contributed to them going to prison, talk to me about the importance of this follow-on treatment through the Residential Substance Abuse Disorder Treatment Act and why that's so important to getting people off of addictive drugs.
Thank you, Senator. As you mentioned, when people leave incarceration, they not only return to use, they're also at much heightened risk for overdose, which is why we're also working in our drug strategy to keep people away from incarceration if they are incarcerated, to make sure they get the treatment. And then upon leaving incarceration, they have a warm handoff to treatment. They may get naloxone, but they get the services they need so they don't return to use.
Dr. Volkow, let me ask you in my remaining time, earlier this year, Senator Feinstein and I, when we were the co-chairs of this caucus, issued a report on marijuana usage and public health and calling for more research into the impact of particularly high concentrations of THC that are used in vaping and the like. And because of the unregulated nature of marijuana, 37 states and D.C. have legalized medical use, 18 states, along with D.C., have legalized recreational use. We simply, I don't believe, have any handle on the concentrations and the impact of these high concentrations of THC on people with perhaps mental health challenges or on the developing juvenile brain. Do you agree that it's important before we legalize marijuana at the federal level, should Congress decide to do so, that we get this kind of research performed so we actually know what we're doing?
I think it's 100% necessary that we actually have an understanding of the consequences of legalizing marijuana are going to have into the children and adolescent brain, and what are the consequences to health to adults. So if they choose to take marijuana, they know what they are taking. Just like with cigarettes, when the moment that it was clear that they were producing cancer, that changed the choices of people. We owe it to the public to actually provide with that information. And we do know already that high-content THC marijuana produces significantly higher risk of psychosis. It's also associated with severe medical adverse effects like hyperemesis syndrome, and has been also associated with strokes and pulmonary disorders. So marijuana is not a benign drug. Some people are more vulnerable to its adverse effects than others.
Thank you.
And I will associate myself with those same concerns. Ms. Valcola, because we were on this subject, let me just follow up with you, because you've pointed out that incarcerated individuals are at a heightened risk of drug overdose following their release. We had a very successful program in Rhode Island that began medication-assisted treatment and support pre-release and then persisted post-release to continue the support for the individual. And we saw a dramatic reduction in overdose deaths, I want to say by 2/3. And I think it was that number that really drove the downward turn that Rhode Island achieved in overdose deaths before COVID. Any further advice to us on dealing with that cohort? Do you support our bill? Should we modify it in any way?
I think that it was a brilliant move on Rhode Island that serves actually as an example of what can be achieved by providing treatment to people when they leave the prisons or jail systems. The results that you all obtained were basically speaking for themselves. And we have taken that study to actually get other states to evaluate similar programs through a network that we're working with in justice settings to determine how to optimally bring treatment either during incarceration or at the moment of release. And importantly, as said before, providing a bridge that will allow those individuals to remain in treatment once they get back into the community. And many of those actions were inspired by the remarkable success that Rhode Island obtained.
Thank you. Mr. Kader, one of the breakthroughs, if you will, of the Comprehensive Addiction Recovery Act was its focus on recovery. We spent a lot of money on prevention. We spent a lot of money on law enforcement. We spent a fair amount of money on treatment and intervention. But for the first time, we started putting some effort into the recovery piece of the population. What did we learn from that experience, and what should we be doing going forward on the recovery part?
Well, thank you so much for that question, Mr. Chairman, and for your leadership, of course. Your landmark legislation, the Comprehensive Addiction Recovery Act, CARA, has certainly set the stage for what President Biden is proposing in his FY22 budget, which is a 10% set aside for recovery support services. You know, recovery support programs provide community-level resources for people with substance use disorder beyond primary prevention and clinical treatment. Currently, there are no dedicated resources to fund these community recovery support programs. And as a result, there's only about 150 of them throughout the country. This funding, if enacted, of course, would provide a sustainable source of funding directly to community organizations to support the development of community-level recovery infrastructure and be available for a wide variety of recovery support programs like recovery community centers.
So part of the problem we had was that with recovery never having been funded before, there was not much of a record of success or failure, not much of a record of best practices. When an area of federal spending and intervention has reached a certain amount of maturity, you learn a lot, and you know a lot, and you're able to spend the money wisely. What lessons should we undertake with respect to recovery? What have we learned in this first go since CARA? And what should we be on the lookout for as we invest this additional 10%?
Well, the biggest thing we learned, Senator, is that recovery is possible for everyone because of CARA. And this builds upon 20 years of grant programs that SAMHSA started with the Recovery Community Services Program, then Building Communities of Recovery, which is in CARA, our Targeted Capacity Expansion, peer-to-peer programs. What we've learned is that this is a chronic condition.
So keep at it.
We have to keep at it, and we have to support people for the long term in order for them not to fall back into active addiction.
And Ms. LaBelle, Senator Grassley and I, after a long battle that actually ended up in another committee, in the Banking Committee, ended up getting our beneficial ownership legislation passed, which provides a lot more transparency into shell corporations and so forth. President Biden has announced a kleptocracy summit internationally to try to clean up some of the pockets of the dark economy around the world, where usually things that are not good for America are ferment. And I want to flag for you the need to address illicit financial networks. The narcotics business is a business, and that means that your production and your revenues are in balance. But if you look at the effort that we put into the production side, for a lot of pretty good reasons, most of our enforcement effort has been on that side. But there's a big financial side of this international narco business. And with these new tools and with this new focus, I think we can do a lot more to address that side of it. And I hope that you will put more focus on that through the national policy as we move forward now that these new tools are in your hand, and I'd like to give you the chance to respond to that.
Thank you, Senator. As you mentioned, there are lots of activities that have happened since the Anti-Money Laundering Act was put into place, which is really a game changer. And what we want to make sure is that the Treasury Department, FinCEN, OFAC has the resources that they need to implement and execute on these laws. As you said, these are complicated global networks of cash, and it requires more than just ONDCP. It requires the Treasury Department, the Department of Justice, FBI, working together to address those issues. And we plan to address this in the National Drug Control Strategy.
Good. Well, I look forward to working with you on strengthening that side now that we have these new tools. Unless anybody has an urgent final question, I will excuse this panel and we'll suspend for a few minutes while we call the second panel together. And may I thank you all for your service in this area and for your testimony here before this committee today. We look forward to working with you. We have a lot of work ahead, and as you saw, a lot of bipartisan good faith interest, so I think we can do big things. Thank you.
Thank you, Mr. Chairman.
Mr. Chairman, while we're changing out the panel, I thought you might like to hear these statistics. In 93,000 Americans died last year of drug overdoses. 20,000 Americans died as a result of a gun incident, plus 24,000 more who died as a result of suicide. So adding those two figures together, that's less than half of the number of people who died by drug overdoses. It strikes me that we're treating those two sort of as in a disparate way. In other words, undervaluing the importance of addressing the overdoses. But I know that's your focus and the caucus's focus, and I thank you for that.
And I thank you for that comment. Let me first introduce our, let me give them a second to get in their seats. So first, we have Steve Gerdak, the group manager for the Washington-Baltimore HIDA's Northern Virginia Financial Initiative and a member of George Mason University faculty. The Northern Virginia Financial Incentive serves as a model suspicious activity report review team. Mr. Gerdak has over 30 years of law enforcement experience and is a certified anti-money laundering specialist, so he's my kind of guy. And I appreciate very much his testimony here today as we look more at the financial side of this industry. Next, we have Keith Humphreys, who is the Esther Ting Memorial Professor in the Department of Psychiatry and Behavioral Sciences at Stanford University. I hope you didn't come all this way just for this.
I also had the great pleasure to go to a wedding in your home state, Senator. So
wonderful.
yeah.
We have very good locations for weddings in my home state. He's also a senior research career scientist at the VA Health Services Research Center in Palo Alto and an honorary professor of psychiatry at the Institute of Psychiatry of King's College, London. So he is a very impressive witness as well. We're delighted that he should be here. And finally, Nicole Alexander Scott has been the director of the Rhode Island Department of Health since April 2015. She comes to us electronically from Rhode Island. She's board certified in pediatrics, internal medicine, pediatric infectious diseases, and adult infectious diseases. And she helped guide Rhode Island through the COVID epidemic in really exemplary fashion, to the point where we're one of the highest performing states in the country right now, with very high double vaccination rates, and schools, businesses, and summer life all reopening. So I'm delighted that she should be here as well. And perhaps I should lead with Dr. Alexander Scott, since we have her signed in, and I don't want to have the technology here foul up. So, Dr. Alexander Scott, please proceed with your testimony.
Good afternoon. Thank you so much. Such an honor to be able to join you, and thank you for all the support that you've been providing to states like Rhode Island as we've continued to battle the public health crisis of substance use disorder. Over the last 2 years, there have been many, many stories of recovery and hope in Rhode Island that are true inspirations, just like Tom Coderre, to every one of us in this field. We cherish those stories. But the truth is that during this time, there have also been many, many tragic stories of heartbreak and loss, some of which can be preventable. After working to bring about moderate decreases in our overdose deaths from 2016 to 2019, we started seeing an increase again in 2020. In 2020, overdose deaths increased by 25% over what we saw in 2019, making it the worst year on record. And the data in 2021 are not encouraging in the least. At this point, fentanyl in counterfeit pills, in cocaine, and in other forms is driving the epidemic in our state. Roughly 3 out of every 4 overdose deaths in Rhode Island involve fentanyl. There is no doubt that the stressors and isolation of the COVID-19 pandemic have contributed to the challenges we're experiencing now. But our numbers started climbing in Rhode Island before we had our first patient with COVID-19. Under the leadership of the governor of Rhode Island, we have an overdose prevention and intervention task force. This is a diverse, cross-sector group that engages every community throughout the state. We're a small state, and we take pride in our direct engagement and all hands-on-deck interdisciplinary approach. The task force is tackling the overdose epidemic head-on, as well as addressing the many underlying issues that are fueling the crisis. We often refer to these as the socioeconomic and environmental determinants of health. Principal among all of them are inequity and discrimination. Every intervention the group considers is evaluated through a race equity lens. In this regard, we are in strong support of the current priorities of the National Office of Drug Control Policy. The major focus areas of Rhode Island's Overdose Prevention and Intervention Task Force are prevention, treatment, harm reduction, recovery, and family and intergenerational addiction issues. I'm giving you this background on our experience and approach in Rhode Island because it really illustrates why we so strongly support these 3 specific pieces of legislation before Congress. Telehealth has been a critical tool for Rhode Islanders during the COVID-19 pandemic, especially for people already experiencing barriers to care. By expanding telehealth availability and flexibility, the Telehealth Response for E-Prescribing Addiction Therapy Services Act would be a major step forward in our work to make treatment as accessible as possible to every Rhode Islander who needs it, regardless of their circumstances. The Comprehensive Addiction and Recovery Act 3.0 gets at those underlying socioeconomic and environmental determinants of health by committing funds to safe and certified recovery housing, pre-arrest diversion programs equitably conducted, and efforts targeting our veterans. So much of what is in CARA mirrors our commitment to going to where people are instead of waiting for them to come to us. That means mobile treatment, warm handoffs, and focusing the public health response in the community. By enhancing public health surveillance of fentanyl-related substances and improving efforts to detect and share data on fentanyl, the Support, Treatment, and Overdose Prevention of Fentanyl Act gets directly at the root of the crisis in Rhode Island. And like the other pieces of legislation I referenced, this act similarly ensures that we are investing in treatment and prevention. I want to wrap up by saying that we are doing everything we can to turn the tide in Rhode Island, but we cannot do it alone. Your support has been tremendous. I only ask you to continue that support and continue investing in the community-focused public health interventions that we know prevent overdoses and save lives. Thank you very much.
Thank you, Dr. Alexander Scott. I appreciate it. It's good to have you with us, even electronically. And I turn now to Mr. Gerdak.
Chairman White House Ranking Member Grassley and other distinguished members of the Senate Caucus, I'm honored to be here before you to give you my assessment on the emerging drug threats and money laundering techniques used by drug traffickers and money launderers, including how those threats and techniques have changed as a result of COVID-19 pandemic. My position as an initiative supervisor for the Washington-Baltimore HIDTA high trafficking area program for over the last 12 years has actually put me in a fairly unique position to have met, associated, consulted, and hung around with some of the best anti-money laundering specialists there are in both the public and private sector. A number of these experts have appeared before congressional caucuses and committees just like this one. Some had helped even craft the Bank Secrecy Act and its recent amendments through the Anti-Money Laundering Act of 2020. Officially, I may only be able to speak from my Washington-Baltimore HIDTA initiative, known as the Northern Virginia Financial Initiative, or NVFI. The NVFI, however, has created a unique network and reputation known far and wide for our innovative work in anti-money laundering and narcotics investigations based on that. It was created through an idea of testing the system that the Bank Secrecy Act had put in place. The logistics, innovation, and latitude provided by the Washington-Baltimore HIDTA for us to do that was incredible. Additionally, we had benefited from an incredible support from the U.S. Attorney's Office for the Eastern District of Virginia. Any statistical data I am presenting is primarily derived from the Washington-Baltimore HIDTA threat assessment report for 2022, and the rest is based on my contact knowledge and just reaching out and sharing this information with many of those experts in that field that I've had the privilege to know. I will skim over my remarks pretty much on some of the, I talked to drug notice in my written statement in the fact that I don't need to convince anybody here the deadliness that fentanyl is to this country right now and the threat assessment it poses. Both the enforcement sector and the treatment sector will agree with that as ranked number one and is now considered, even that rank number one is now considered kind of understating the idea because fentanyl now is being used as a cutting agent for almost everything to include marijuana. And, and it has all, like any other drug, has all the violence associated with it. The other thing I'll mention is the fact that when I was talking to some of the experts is this little kind of forgotten threat that marijuana trafficking seems to be the violence threat marijuana trafficking seems to be still creating out there, despite the trend towards legalization, decriminalization. The Washington-Baltimore HIDTA report reported a large increase, as well as the conversation I have in violence associated with marijuana trafficking, although police and law enforcement are not enforcing it anywhere near the capacity they did before. It may be initially surprising, but it's not so much if you think of the fact that you've got a lot of novice people entering the market, so you have more dealers, and they're not being confronted by law enforcement as they are being threatened by their competition. The threat assessment report from the Washington-Baltimore HIDTA showed an easy availability of all drugs, maybe some slight increases. There were concerns about some of the these more designer drugs out there and their usage, and I can assure you with these designer drugs, a lot of that usage was actually tainted by addition of fentanyl in the report. What I want to get to before anything else is I'm the money side of the house, so the money talks out there, and for this purposes, I want to be able to report to you that COVID-19 actually created an incentive for us, or it actually created a new, unique opportunity to redefine what normal looked like. With fentanyl out there, with the COVID restrictions out there, a lot of the money laundering techniques had to change. For example, businesses that were pouring a lot of cash through them prior to the epidemic would have a hard time explaining how that cash went through the system. In that sense, to keep my remarks brief, despite all the emerging threats of cyber currencies and those items out there, cash is, I have to report to you, cash is still king. The FinCEN reports, various newspaper articles and everything I've stated in our remarks show that cash is still the number one out there, with a 44% increase of the transmissions below $10,000 reporting requirements. I would like to report to you that under the Bank Secrecy Act, to include the partnership with the financial organizations does provide us with a unique opportunity to better track these things. What we do need is more people with knowledge in the anti-money laundering world to attack this problem from that aspect.
Thank you, Mr. Gerdak, and we close with the very distinguished Dr. Humphreys. Thank you, sir, for being here and for closing our official testimony.
Thank you, Chairman Whitehouse, Co-Chairman Grassley, and distinguished members of the caucus. I'm honored to speak with you today. My analysis of the opioid crisis reflects my decades of work as an addiction researcher at Stanford University, as well as my service as a White House drug policy advisor in the administrations of George W. Bush and Barack Obama. I'm going to focus my remarks on three key issues: tracking the epidemic, preventing it from spreading to other countries, and facing up to the new world of synthetic drugs. So first, tracking the epidemic. One of the signs of our government's productive response to COVID is any of us could pick up our phone right now and find out how many people got COVID and how many died of COVID in any state in our country in the last 24 hours. Contrast that to the fact that opioid overdose data gets to Washington 6 to 12 months after the fact. Our current survey tools do not provide credible estimates of how many people use heroin or fentanyl or are addicted to these drugs. As a result, we cannot design policy based on the status of the epidemic because we don't know what it is. It would therefore be a wise investment to restore lost public capacities in this area, like the defunded arrestee drug abuse monitoring program, or the significant data analytic capacity that ONDCP used to have but doesn't have so much anymore. We also could build a national infrastructure using wastewater technology to monitor for new and emerging drug threats. Point two, we need to stop the opioid epidemic from spreading beyond North America. COVID has taught us the painful lesson that one country's health problems can become the world's problems. That could happen with the opioid crisis. Federal officials, including members of this very caucus, exposed the role in the opioid crisis of people like the Sackler family and their company, Purdue Pharma. Fines have been levied along with constraints on various fraudulent practices that were used to promote opioid drugs like OxyContin in the United States. However, like the tobacco industry before them, some opioid manufacturers have now shifted to expanding opioid prescribing abroad. For example, investigative journalists have documented that the Sackler family is expanding opioid markets through a mirror company of Purdue Pharma, known as Mundi Pharma, using the same tactics employed in the U.S. Los Angeles Times has reported that among the countries where Mundi Pharma is attempting to promote OxyContin are Brazil, Colombia, Egypt, Mexico, and the Philippines. Investigative journalists at The Guardian document Mundi Pharma is one of the many Western companies promoting opioids in India using tactics pioneered in North America. Without intervention, those countries will suffer as we have suffered. We have a moral responsibility to people around the world to not be satisfied by simply bringing our own opioid problems under control. I urge the caucus to investigate the international activities of U.S. opioid manufacturers, to warn nations around the world against their conduct, and to do everything possible to ensure that constraints on fraudulent and corrupt practices apply not only in our own country, but in other countries where these corporations are active. Point three, and finally, we need to rethink drug control in light of the increasing prevalence of synthetic drugs. The increasing availability of fentanyl and of methamphetamine are only the two most prominent demonstrations that global illicit drug markets are increasingly able to produce large volumes of drugs whose production is not dependent on agriculture. Traffickers reap enormous financial advantages from not having to grow drug-producing plants in politically volatile regions or secure peasant labor to farm it. Eliminating the risks of drought, crop blight, and bulk shipment interdiction are also attractive to drug traffickers. These economic advantages of synthetic drugs, coupled with the internet spreading the needed information and technology to synthesize drugs and to facilitate their covert purchase, raises questions about the basic assumptions of global drug control strategy. As drug production moves increasingly from something that depends on agriculture to something that any chemist can accomplish in their sink, some long-standing policies and programs have diminishing returns, like, for example, trying to reduce drug crops in poor countries. Transnational drug trafficking itself may also diminish as domestic retail sellers can make their own drugs rather than rely on large criminal organizations to import them in bulk. This has substantial implications for where domestic law enforcement and international border control agencies direct their energy. Dealing with this new world is going to take sustained thought, study, and discussion. If your caucus wishes to use its convening power to lead that process, I know I am only one of many drug policy analysts who would be pleased to assist you in formulating an approach to drug policy that measures up to the challenges posed by widespread synthetic drug production. Thank you very much.
Thanks, Dr. Humphrey. The order of questioning will be Senator Grassley, Senator Cornyn, Senator Whitehouse, unless others arrive.
Thank you. Mr. Gurdick, you mentioned in your testimony that COVID-19 changed how drug traffickers do business. Drugs are increasingly exchanged online and not on the street corner. Traffickers use the internet and even door-to-door food delivery services to spread their supply. Obviously, drug dealers are adapting, and so should we. How can the federal government's approach to combating drug trafficking adapt to be more nimble and proactive, or have we already adapted?
From the drug trafficking side, I mean, we've adapted okay. I still, I come here with a firm belief that we have very underused the intelligence information that we can get through the Bank Secrecy Act, through things like SARS and the FinCEN information we have out there, just exposing more of law enforcement to the ability to attack these organizations from the money level instead of sometimes from the street trafficking level.
How do to you also, how do high-intensity drug trafficking area programs respond to emerging and evolving synthetic drugs like fentanyl, analogs, and methamphetamine?
It seems like out there, and I think if you look into my testimony, and in fact, when I was listening to some previous testimonies from this, because this is a very new experience for me, somebody mentioned the fact that, criminals are very agnostic about their crimes. We are seeing over and over again, there's no particular drug anybody sells anymore, like almost exclusively. So we're seeing the synthetics as well as the other stuff all mixed together. So I don't know if you can separate the two, because it seems like our experiences are seeing that, they'll do whatever they can find and whatever they can get a hold of, and it doesn't really matter, to try to target one thing versus the other, because they're all over the map with the drugs they'll sell and deal with.
Lastly, also to you, what common trends have you observed over the past year as it pertains to drug supply and abuse, and what successful law enforcement efforts should mimic post-pandemic?
Well, I said, as like in my remarks, I am the big believer, one of the people out there waving the flag that we're vastly underusing the resources being presented to us by the Bank Secrecy Act, and getting that information or the idea of following the money brought down from the macro level of the international trafficking to the micro level of the local drug dealer in our area, and even better identify that even from the overdose thing, not necessarily charging people with money laundering at lower levels, but using that as a key form of evidence to try to go after some of the other dealers and preventing some of these overdoses.
Yeah. Dr. Humphreys, you've stated that we ought to rethink our drug policy in light of increasing prevalence of synthetic drugs. Obviously, I agree with that point. Synthetic drugs pose an enormous risk because they can be easily manufactured, imported, and trafficked. I'm working on bipartisan legislation to proactively control synthetics. Right now, we're playing a deadly game of whack-a-mole as law enforcement tries to keep pace with drug trafficking organizations, and that ought to stop. So my only question to you is, how can the federal government proactively detect and stop the flood of synthetic drugs, and what strategies should this caucus consider in approaching the unique challenges of synthetic drug use?
So it's a big question, and I would not claim to have all the answers to it. Certainly, we have had success with synthetics with precursor chemical interdiction. There were successes with methamphetamine that could be exploited and also could be relevant with fentanyl. There also might be things to do over the internet, for example, creating spoof sites that do denial of service attacks to internet-based sellers, or setting up fake sites that block off people's credit cards or block off cryptocurrency transactions. But there's many, it's going to take a lot of thought and a lot of work, and be very pleased to work with you and your staff on that in the years ahead, sir.
Thank you, and I'll yield back my time.
Thank you very much, Senator Grassley, and include me in that conversation.
Yes, sir.
Let me start with Dr. Alexander Scott. Part of the traumatic effect of COVID was that it required breakthroughs in certain areas, and one breakthrough was in the area of telehealth. And in one particular area in telehealth, we got emergency regulations that allowed providers to prescribe medication-assisted treatment via audio and video after an initial, audio only, in some cases, after an initial in-person or visual appointment, and then to go ahead and bill Medicare. That has been, I think, very successful. And Dr. Alexander Scott, if I could ask you whether you think that should be continued. It's there as a temporary.
Thank you, Senator.
If there is a temporary program right now, should we make it permanent, and why?
We absolutely should make it permanent. Telehealth provides another, we want to be able to access every tool that's possible. Whatever door you enter, that's the door we want to make sure that treatment is available. And so if that's your primary care provider, and if it's engaging just via telephone as opposed to traveling to a healthcare facility, we absolutely have to have that as one of our resources available in the toolbox.
We've, in Rhode Island, done a number of things. We've already talked about the medication-assisted treatment delivered through transition out of our ACI, our penal facility. We have not mentioned that in Rhode Island, if you overdose and are taken to an emergency department, you get prescribed a peer recovery mentor. You may not take him up on it, but you're not going to leave without a connection. That addiction professionals have been embedded in a number of our police departments to do follow-up on the night calls and to make sure that if there's an addiction issue, it's highlighted early. And we've made fire and police stations points of entry for people who need treatment that don't know where to go. Those, I think, have been very effective interventions, and I'd like you, Dr. Alexander Scott, to comment on which ones you think were the most effective and how they work together as a group.
Thank you, Chairman. One of the parts that's critical to our response that I shared earlier is the interdisciplinary all-hands-on-deck approach. While we know that there is not one sole solution, we do know that when many effective evidence-based solutions work together, we can have the greatest impact. And given in particular how significantly COVID and other elements of the syndemic that we're in have impacted the opioid epidemic that we are dealing with, we want to for sure continue each element. We've established the levels of care within our hospitals, which are voluntary designations that require certain qualifications of standard bare minimum elements of care apply to every individual who comes into the hospital. And so, as you mentioned, that not only includes providing a peer recovery coach being, or peer recovery specialist being offered to that individual. It also involves screening for drugs if someone comes in with other scenarios. It also involves being able to be referred to treatment and other referral services, as well as being offered naloxone, along with many other elements, including access to medication-assisted treatment, which we know is critical as well. With the other life-saving interventions that you've relayed, it's really all about meeting people where they are. So ensuring that people have access and can just walk into one of our local law enforcement or first responder or fire stations that are available and automatically be able to be connected to treatment and, importantly, recovery services is critical. And then certainly a focus that we have really begun to build out is targeting upstream more so, addressing determinants of health, making sure that people have access to sustainable housing, making sure that we're addressing our race equity concerns, discrimination and other challenges that exist for communities of color, making sure that people have access to jobs and employment, transportation, and other elements that we know are critical to not only prevention, but also building recovery capital.
Thank you very much, Dr. Alexander Scott. Mr. Gerdak, to use your phrase, on the money side of the house, cash is still king, and cryptocurrency and dark web exchanges have not caught up yet. Do you think they will? What's your projection?
I think the fear, well, right now, I think you'll see in my written remarks, the fear right now out there is that the acceptance of those currencies at that macro level, that transnational drug organization level. What we're seeing at a kind of I call it local, the micro level, is people are testing those things out to use it. But I've done a lot of, I mentioned in remarks, I looked into one case about even a transnational level. And when you get to the bottom line, everything seems to originate with cash being dumped into the system at the smaller level that an SAR review team like my own, or the NVFI, is capable of using with the right people knowledgeable in how to use it. There's been obviously some growing pains in trying to use the Bank Secrecy Act properly, but I'm one of these people that just love the Bank Secrecy Act and what it could provide us if properly applied out there. So,
well, if you don't mind, I'd love to ask you to follow up on that with a question for the record. Mm-hmm. Just to get your advice, you also said that you think we're dramatically underutilizing our capabilities with the Bank Secrecy Act and the Laundering Act. Love to get your advice on what we should do. On the drug side, it's an equally big business on the financial side, otherwise it doesn't work.
Oh, we fully agree
So
with
you
that.
got to get after the financial side too, and I appreciate your service in that respect. And if you could follow up with like a written list of recommendations, I'd really be grateful to you.
Yeah, no, you saw my passion is that side of the house, and I just think it's very underutilized. I've called the lack of knowledge within law enforcement about what the Bank Secrecy Act can do the broken window in that approach. I think that was an appropriate analogy to it, because I am just seeing good investigators who can be trained but just haven't trained in that aspect, and I think there's great things we could do if we had.
Well, I'm with you, and I had the FBI take me for a spin a few years ago on the dark web and a secure computer that they run, and that's a pretty astonishing place too when you look at what is just flagrantly for sale right in front of you. So look forward to working with you.
Yes, sir.
Dr. Humphreys, as I saw your testimony about what the opioid manufacturers and marketers are up to in foreign countries, I had a real sense of, deja vu all over again, because I was around through the litigation with the tobacco industry over the fraud that the tobacco industry committed in marketing its product. I was an attorney general, and it was attorneys general who filed the broad litigation that caused the generic settlement. But the U.S. Department of Justice did its own thing by bringing a civil RICO lawsuit against the tobacco industry and getting a very solid judgment. I mean, well over 1,000 pages. The judge just nailed them. That what they were doing was, in fact, fraud, and they were put under order to knock it off. And what you saw after that was that they did in fact knock it off in the US where everybody was watching, but they took what seemed to be the exact same marketing tactics, and they went to other countries and deployed exactly what had been described to be fraudulent and illegal in the United States, and did that exact same stuff elsewhere. And I think Brazil was one of the countries that was one of the targets, and it showed up in your testimony as one of the targets. So here we are, 20 years plus later from that, and it seems that the opioids are up to the same thing. You've looked at this for a long time. How would you describe the analogy between the tobacco export of its wrongful U.S. conduct and the opioid export of its wrongful conduct?
As it happens, I use that very same analogy, Senator. It is exactly parallel. Tightening regulation and end of corrupt, misleading practices in our country as well as in Europe. And they just then went to, poorer nations that they could push around with their enormous wealth. I think it's critical in this, moment where we are finally holding companies to account that the restrictions that are placed on them in these lawsuits do not have U.S. limitations on them. In other words, if you are a family who owns one such company here and another somewhere else, the same things like covertly paying doctors, saying OxyContin is not addictive when you know in fact that it is, incentive bonuses, overshipment, all the things we saw here, they have to be prevented entirely. Otherwise, we'll be letting our friends down around the world, and there's just a lot of suffering that I'm sure you would like other countries to not go through as we have gone through.
Well, I look forward to working with you on this as we proceed. I appreciate very much your attention to this. There's a movie called Casablanca, and at the end, Humphrey Bogart and Claude Rains walk off through the airport in the rain, and one says to the other, "Louis, I think this is the start of a beautiful friendship." So maybe this is the start of a beautiful friendship with us, Dr. Humphreys. I certainly hope so. We have a lot of work to do. The record of the hearing will remain open for 1 week. So if anybody has anything to add to the record of the proceedings, that week is what you'll take. That gives you a week, Mr. Gardeck, to try to get your advice into us. I appreciate very much you're willing to do that. I thank all of the witnesses for participating and my colleagues for participating. And we're off to a good start. And I hope that we can do a lot of good work ahead to end this scourge. Thank you all very much. Hearing is concluded.